Thank you, Julio. Professor von Braun, Commissioner Gabriel, colleagues and friends. I've been asked to say something about the problems, increasing problems we have with the more complex cancer research and cancer therapeutics and care. Oh. What happens? This is this one, okay. Okay, so I have a few main messages here. As we heard from Michael Baumann, inequalities in research will convert to inequalities in therapeutic care and prevention. No doubt about it. We see that clearly. Innovations from basic biological and technological research demand increased infrastructure support for clinical and research activity. And that's the main problem if we would like to defeat the inequalities, because this creates an increasing disparity between countries and between poor and wealthy countries. So what we would like to say, and these are analysis of research strategies and infrastructures for, I would say, for more than 20 years among several of us in Europe. We say a structured, coherent research continuum, that is translational cancer research, fosters innovations and mitigates inequalities. And that was said already in 2005. If we look at the cancer research, we have heard from Elisabeth Weidepass about the epidemiological situation. We have to decrease incidence, and of course, their primary prevention and prevention screening are the most important tools. We increase all the time survival more or less, I would say. So we are building up a large population of patients with chronic cancer disease. And cancer is starting to be one of the main and most problematic chronic diseases. We need to increase the cure. And we have good possibility now when we move into precision and personalized cancer medicine. And here we need to increase the cure in order to prevent building up the chronic cancer disease. We need also improved health-related care, quality of life, because we look more and more at patients. And then, of course, everyone says that cancer is a tremendous economic problem for all countries, actually. So we need to find a way to establish cost-effective cancer therapeutics care as well as prevention. And I think the last point is very strong. We decided already 2005, 2007, that we define translational cancer research as a research that covers the whole cancer research continuum. And for therapeutics, it looks like this, that we start with the basic research, move into preclinical research, then into clinical research. And after clinical research, we have an adoption in the healthcare system. And then we need to follow up what is going on in the healthcare system by outcomes research and health economics. And we have heard about the long-term follow-up, the cancer survivorship. It's important to see that such a continuum is bi-directional. It's forward usually as we talk about it, but it's also backward by reverse translational research, which is becoming a more and more important research component. We have the same situation if we go to prevention, and Chris Wilde many years ago said that when we establish this continuum, it looks about the same in prevention, where we need the early translational research with the basic research, moving into an identified prevention context for intervention research and further to adoption into the public health organizations. And then again, what is said repeatedly, outcomes research integrated with health economics are missing elements also in this area. I would like to say that again, even if we see it clear here, all of us agree that we should have it there. We don't see it practically anywhere. I'm a little bit provocative now, but it's important to be it. If we look at the basic and preclinical research, we can say that basic biological and technological research innovations are expanding at a high rate. And that is very good, but it's a problematic situation for the clinical prevention cancer research because that part is time-consuming, complex, so it's not balanced. So here is a big problem in order to arrange for the translational research. Preclinical research innovations should move into proof of concept clinical trials, and for prevention, we need the prevention context for intervention. As I said, reverse translational research is important, and it increases over time because we have better and better possibilities to get biopsies from patients, for instance, during treatment, and the technologies are improving all the time, so we can go back and have very small cell samples and follow up what is going on during the treatment. And we can ask questions back to the basic preclinical research, let's say about the failing therapies and so on. There are many questions. So what we say here is that we need to have more close interactions between basic preclinical and clinical research for prioritization and expansion of preclinical research. And that is an urgent need. If we look at translational research, the early translational research, we used to say that this leads to drug development of anti-cancer agents. But I would say you have several areas that should be there. The causes of cancer, targets and biomarkers for prevention screening, diagnostic and preventive technology, radiation therapy, combinations of anti-cancer agents, immuno-oncology, combinations of treatment modalities, and health-related quality of life. And this is not all, but I would like that there is a need actually to look more carefully at the early translational research for prioritization and prepare for the clinical trial. I think we could look also a little bit more careful at the continuum covering the clinical trial. Let's start with proof of concept clinical trials, moves into phase 2 and next generation clinical trials. But before coming into implementation, we need also practice-changing clinical trials for treatment optimization studies if we go to a multimodality treatment. And here we need the randomized controlled clinical trial with the outcomes of clinical efficacy involving also health economics. Because if we have that information, we can go into the implementation research in a structured way and look at total patient population for clinical effectiveness and health economics, which means that we will have information of cost effectiveness. And I think if you ask the healthcare organization, wherever you go, they ask for this information because they have difficulties actually to prioritize what to bring in. Yeah. If we look at the coherent translation cancer research continuum representing translational research, we see clearly that we need to pay attendance to some areas here. We need to promote, as I said, preclinical research better. We need to work towards a critical mass of infrastructure of patients for molecular stratified clinical trials. We need, as we said, practice-changing and treatment optimization clinical trials. We want to know the clinical efficacy linked to health economics. We need the implementation research because we need, in order to be safe when we introduce innovations into the healthcare, that we know the clinical effectiveness and health economics. Again, we need to integrate outcomes research and health economics in the research continuum. And here we need also to integrate the health-related quality of life research, an area which is expanding very much and has a very important function actually for the life of the patients. And that should be an integral part of the cancer research continuum. Another important factor, which I would touch very, very briefly, because Simon Movers will talk about this, we need the integration of cancer therapeutics care and research. And that was also a conclusion from an EU project 2005 to 2007. Otherwise, we are lost regarding establishing translation in cancer research. We need the comprehensive cancer center, quality assured center. And I say we need that these centers take responsibility for a defined geographic outreach area. And that is critical to offer more patients high quality care and access to new treatments and also research activity. We have at present about 35, a little bit more than 55 such centers in EU, but we need more than 100. We are on the way, but this must move on quickly in the future. And we need networks with the comprehensive cancer centers to guarantee the critical mass, but also to coordinate research on the in this case, European level. So I would say I skip governance. Simon can talk about that later on. But if we have suboptimal organization of comprehensive cancer activities, then we will have inequalities that will increase in the future, both within countries and between countries. If we look back to the drug development process, it's often incomplete. And I will just say that this may have negative effects and also effects regarding inequality. The final steps of drug development are often missing, and we talked about the lack of information on clinical effectiveness, cost effectiveness before implementation. That will be, if we lack that information, it happens that we treat with new anti-cancer agents that have too small or no effects at all. And I can tell you that we have repeated evaluations now, if you go to PubMed and look at it, that we can see that a lot of the new anti-cancer agents are not studied carefully enough for use in the healthcare system. Yeah, what happens of that? Yeah, if anti-cancer agents have insufficient anti-tumor effect, that increases the cost for the clinic without expected positive effect. The other side of the coin is that potential side effects may increase cost further, because most of the anti-cancer agents actually have negative effects. And the worst of all is that this has a bearing on the quality of life of patients. So I would like to say this is a very, very important ethical question, and we should look carefully at that. We have a complete drug development process before we introduce it in the healthcare. And it has also enormous economic consequences. Histogenetic human classification may be history fairly soon, because now molecular classification of patient stratification for diagnostic trials are moving and increasing. The majority of patients are diagnosed and treated outside comprehensive cancer centers. Infrastructure support for stratification of patients, molecular pathology, omics, etc., should be available at well-developed cancer research centers. That's comprehensive cancer centers mainly. Sharing patient data and biological samples infrastructure, both at the national and international level, that is a must to create the critical mass to develop precision cancer medicine. So without sustainable collaborative networks, we will not be able to reach the critical mass. We have a suboptimal development of precision cancer medicine, and that will increase the inequality both within and between countries. Another area we said is the health-related quality of life. That is also important because we see tremendous differences between countries and within countries. So we need to do that. I don't know what is wrong with this. Oh, here it is. We need to go into this fairly wide area, also looking at the improvement research on supportive care, rehabilitation, psychosocial oncology. We heard that a few minutes ago, survivorship as well. And we should not forget palliative care and end-of-life care, because more than 50% of the patients die due to the disease. So to end up, I would say that we say that inequalities are depending on that we do not implement evidence-based diagnostic therapeutics and prevention in all countries, and that should be done. And as in Europe, the mention for the Europe's Beating Cancer Plan. This is not such a big thing because this requires implementation research, outcomes, and health economics, and then you can have it there. A coherent research continuum will increase in innovation and will develop cost-effective therapeutics care and prevention with relevant tools. I say we will have the tools for prioritization in the healthcare system. Sharing resources, we said, to develop precision cancer medicine research with strong infrastructures, etc., treatment of patients where they are living. That will be important in order to have advanced clinical research available for more patients, and that will limit inequality. So national and international translational research collaborations will increase the use of innovations from basic and preclinical research. It will innovate clinical and prevention research to develop cost-effective, affordable prevention and therapeutic care. And with the risk to bore you, I say again, optimization of a coherent cancer research continuum, translational cancer research, will limit inequalities and at the same time increase innovation. And that is what we will discuss now in 3 different sessions today and tomorrow. Thank you.